the culture of safety that you need. And in the culture of safety data, I can't do it. Now, it could be that that's just a secondary effect of the way the survey was done, but I don't think so. I think this is the way you think about your physicians relative to the system and the way it's designed, unit by unit in the Mayo system. So if we come back to the unit, I need to be able to see the leaders and the teams and the accountability work, and then built on that then is the learning system. And the learning system then is a process of continually evaluating how am I doing, do I have the information that I need, what are the defects in the system, and then working to working to improve them. So where do you see some of this kind of manifest? So the Keystone Project is a really nice example, the Michigan ICUs. Many of you might know it, but let me just remind you what happened here. Here again are the attitudinal surveys, 1 to 100, are reporting good teamwork climate. Prospectively, before they come in and do anything, they evaluate teamwork, and they have a number, each bar stands for an intensive care unit in Michigan. This group of intensive care units has low teamwork. This group of intensive care units has medium teamwork. This group of intensive care units has high teamwork. They just divide them into 3 cohorts. And then they come in and say, here's this checklist, put in central lines, do it better, all right? And don't get bloodstream infections for 5 months over the next year, and we'll come back and measure and see how you do. And so that's what happens, and what occurs is this. 44% of these ICUs manage to achieve the goal, 31% here, 21% here. So then you ask the question, is there one specific question in the teamwork climate set of questions that links whether or not an intensive care unit was able to achieve the goal? And the answer is yes. The strongest predictor of clinical excellence, caregivers feel comfortable speaking up if they perceive a problem with patient care. People speak up about their concerns. So now I go back and I look at your culture survey data. Your strength is that you choose clinicians with the right kind of values. You have the human as hero model more than other institutions, and it works for you for a variety of reasons. But in that, you have designed a system where at least 40, but close to 50% of your folks in the culture survey say, I'm afraid to speak up about my concerns to another person. And that, is it an Achilles heel? I don't know, but is it a challenge for you? Most certainly, most certainly. All right. So a little more examples about what happens with this culture survey data when you use it correctly. Over here, we're looking at 24 intensive care units in the state of Rhode Island. And it's a nice little study. I'm not sure it's, Steve was looking at the data, he said, I'm not sure that this is statistically significant, but it's interesting. So let me show it to you. Each year they do the safety attitudes questionnaire, the culture survey. And you notice, year on year, nothing much changes, except all of a sudden in 2009, things improve across all of the domains, teamwork, safety, perceptions of management, and so forth. And I have 2010 data, I just don't have it in here, but it stayed up in 2010. So you ask, well, what happened in 2009? Well, the answer is that in 2007, what they did is they took the culture survey data and they took a special, specific debriefing form, and they said, debrief the culture survey. Go and talk to people about what you see in the survey that's good and that's bad and that doesn't work. 9 of the intensive care units did, 14 didn't. And interestingly enough, when you divide out the 9 and the 14, the 9 that did improved their scores across all of the domains. The 14 that did not debrief didn't improve any of their scores. They were either neutral or they went down. Not by a lot, but there's a trend when it's across all of the domains. But more to the point is that while the culture surveys improved or didn't, they did achieve some change in their central line infections and VAP rates. Those that debriefed, decreased 10, 15%. Those that didn't do anything, 2.2, 4.8%. There was just enough of a difference to say, wow, this is interesting. So the next year, everyone debriefed, and you suddenly see a bump up in the culture survey scores. We're just getting these little hints, Kaiser and the data coming in from Northern California. I mean, I could go on and on. I've got a whole long list of cases like this that are getting, and the Michigan study is not That's good, hard data. All of the others are kind of hints that are coming in that says this stuff makes a difference. It makes a difference culturally, it makes a difference clinically in the long run. The debriefing session's pretty formal and rigid now. The way we run it is, you want to get something on the order of about 20% of a unit to look at the information in a focus group that they feel very safe in having conversations. Leaders and managers organize, print the debrief forms with the information on them. I'll show you what that is. And then you get people to have a discussion about, well, what do we see in our data? And what gets printed out on our forms are the least positive versus the most positive scores in the attitudinal survey. And then these are the questions. What item is of concern to you? Why is it important? What are some specific examples to illustrate how this reflects your experiences? Envision the ideal unit. What would it look like if 100% agreed strongly? And what actions might you want to take to improve the environment? So it's just going straight at the heart of the matter, which says, you're telling us how you feel, what your perspectives are. Now, let's you have a discussion about what you think ought to be done. And if you do it right, where you kind of require this. Now, Kaiser's requiring it. Catholic Healthcare West is requiring it. In the organizations we're working with, there are very large institutions now that are beginning to say we are taking this on whole hog. So I think there's going to be I know there's going to be a lot of learning in the next year or so about how to do this and how to do this well. And the devil, again, is going to be in the details. So who should be talking to each other? Nurses talking to nurses, docs to docs, or should we make it multidisciplinary? There's all sorts of little devil in the details issues that I think we still have time to learn and will over the next little while. Right. So understanding this, let me just round out one or two of the other components here, and then I'll stop. One of the aspects of teamwork is how do you simplify it down to make it easy to understand? Now, the interesting piece is that, I was part of the service collaborative here 2 years ago where teamwork was being discussed, and Steve Swenson and James Dilling and Joyce and I have talked about the direction that Mayo's going in terms of behavioral choices and safe behaviors. Let me give you what I think is kind of my simplified version about how I think about teamwork, because teamwork is all about behaviors, there's no question. I do think there's a way to kind of think about it in a way that's reasonably simple, and it essentially looks like this. If you want a team to function effectively, now if you want a unit to function effectively, any unit, what needs to happen is that when the group of people come together at the beginning, they have to plan forward. Then, at the end, now that you can define end however you want. If it's an operation, it's the end of the operation. But if it's the end of the shift, it's the end of shift. The end of the day, it's the end of the day in the clinic. Define it how you want. But you plan forward at the beginning of the day, and you reflect back at the end of the day on what you've done. So Joint Commission, others are kind of mandating this process in operating rooms. We're not mandating it anywhere else. But if you ask me, we are, any interventional area, but not in ambulatory clinics on the units. But when you think about it, the nurses and the social worker and folks, they come together and it's 6 or 7 or 8 in the morning and you're on a unit and the physicians kind of begin filtering in and out as they're seeing their patients. Where's the briefing? Where's the planning forward for the whole group? Because we've got very sound data from intensive care units, for example, in the Johns Hopkins studies, that if you don't do that right in an intensive care unit, understanding what the daily plan is for the patient turns out to be accurate 10% of the time. You do it right and set up daily goals, it goes up to 80, 90% of the time. So groups have to plan forward. And then, at the end of the day, they have to reflect back. That debriefing process, the reflecting back, is the overlap between teamwork and improvement. You can't do improvement without it, and you're not a team if you don't do it. So to what degree do groups of people get together and reflect back on what they've done? Well, we never have time. And my answer is, you don't have time to not debrief. So teams plan forward and reflect back. And then in the middle, when they're all working together, you come up with some standard mechanisms to communicate clearly. SBAR is one of them. And you want to come up with some reasonably straightforward ways to resolve conflict, because teams generate internal conflict just by the nature of what they do. This is teamwork. But, the communicating clearly, simple but hard. Communicating clearly, resolving conflict, we can go on a long discussion about those, but we can get at those. But it's that briefing and debriefing part that I find so interesting, and especially the debriefing one, because the debriefing determines whether or not you've got what you need for the learning system in the unit. I mean, when you've got a learning system, what are they going to work on? Well, what they're going to work on is what they learn. And what they learn comes from a variety of places. We get our quality data and our outcomes. That's great. But the other piece that you want to learn is what went well and what didn't go well that day, right? And now, how do I then take that and apply it in a learning system to make it go better the next day? For example, we had a patient come up from the emergency room who was only here for an hour. We had to call the rapid response team, and then they went to the intensive care unit, right? That did not go well today. Let's debrief the process. Let's go down and debrief with the emergency room. And so when I have the discussions about how that transpires, the answer is, well, we don't debrief it at the end of the day. It's just the status quo, and I'm not sure that I can go and debrief it with the emergency room because I'm not sure that they'd be positively disposed to have the discussion with me. So those are the issues at Mayo in terms of how this cultural piece kind of has affected my thinking when I look at that overall cultural survey data. So let me stop so I can take a few minutes for questions, but I'll encapsulate what I've just described to you. As I look, and perhaps what I can do is I'll just go back for one sec and look at your data just to cover it without giving people seizures as you look at these slides. You have enormous strengths. These two little bars up here, as I mentioned, are some of the most powerful that I've seen in terms of how people perceive leadership and how people perceive the organization. You have some issues around a perception of being punitive that I think is probably linked to your, clinician, nurse, humanist hero perspective that actually works for you and it works well. You've got some structural issues relating to hands-off and transitions that are interesting, but if you take them on, you'll manage them. But the challenge that you've got is, how are you going to create an environment where people can speak up about their concerns? And why is that key? Because it looks to me as if that one issue from the Keystone Project, that one ability, is going to determine whether or not units can improve effectively over time. And that's showing up to be one of the most important pieces in the armamentarium of producing effective teams and producing effective improvement, is that ability to speak up about concerns. And that, I think, here is the challenge that you're going to need to take on and address. So let me stop, and I'll be happy to answer questions or comments. Actually, hold on, and you use the mic. It's always easier.
Have you heard the phrase Minnesota nice?
I have indeed seen it.
Because I've heard two of our senior leaders articulate that they think that the reason people don't speak up at Mayo is because of Minnesota nice. I'm just curious of your comments. My perception when I heard that was that just shuts down communication and opportunities to resolve the issue if the senior leader of a department says it's because of Minnesota nice that our allied health staff doesn't speak up.
Yeah. Well, I don't think Minnesota nice is only in Minnesota. All right? I mean, that's for a start. There are reasons why people don't speak up that are wide and broad, and not just being polite and nice. And for those many reasons, all of which exist at Mayo, that briefing process in the morning, when people started saying, well, why do you do a briefing? Why do you start off planning forward? A piece of it was, oh, well, we want to know all the things we need to know in order to take care of the patient, know the game plan. Well, yes, everyone needs to know the game plan. But from my perspective, that's not the primary reason why you're doing that briefing. The primary reason why you're doing that briefing is because the leader of that team, who usually is a physician in healthcare, has a responsibility to create within that environment, in that moment, the psychological safety to make it easy for someone to speak up about their concerns. And it has to be stated then and there on that day in that second so that it'll last for the few hours and sweep away the Minnesota nice. All right? But it's not only Minnesota nice you're getting rid of. There's all sorts of other reasons why they won't speak up. But it's their job to create that environment. So I agree with you that the comment you're describing would be problematic. Yeah.
Thank you very much for an absolutely fascinating presentation, and absolutely brilliant because it makes perfect sense to me. I'm interested very much in the interaction between occupational safety and patient safety. And as an industry, the healthcare worker is in the most hazardous occupation, more likely to be injured than in manufacturing or construction or any of these things. If we're not taking care of ourselves in the environment of care, which is also our environment of work, how does all this play in, and have you explored that at all, and the overlap between culture of safety in the occupational world and the patient safety world?
Sure, no, look, it's a lovely question. Yeah, I think we're down there with airline baggage handlers, actually, in terms of our, what has our worthwhile. So the direct answer to your question is, I haven't specifically looked at it, but I will tell you, but let me actually surmise a couple of things. One of the concerns would be especially if I'm a nurse with back injuries, because that's like the classic, all right? So if I'm standing there with a back injury, am I saying to myself, the organization didn't care about me or doesn't care about me, and I'm getting my back hurt because the hospital, whatever it is, isn't making an effort to in my best interest, my care. And the interesting piece is that for you guys anyway, so I can't speak in general, but if you look at these questions down here, these questions actually pertain to, do I like working at Mayo, and do I feel that Mayo takes care of me? And the answer unquestionably is like, in the green, 80%, at least 8 out of 10, is yes. I feel like they're taking care of me. So I can't speak specifically. If you went and asked the nurses and I'm targeting the nurses, but it's everyone obviously, but it's nursing, especially with this back and weightlifting stuff. You may get a slightly different perspective, but overall, it would appear that at Mayo anyway, that is not a concern. But I think it's an issue in our industry. I think it's unbelievable that we have such a high occupational error rate. Yeah. Did you have a follow-up? Yeah. Yeah, please.
When you talk about the culture within the healthcare world, however, there is a long and well-established cultural norm that says that it's perfectly acceptable to sacrifice one's health on behalf of the patient. Yeah. So to some extent that drives this behavior, and one wonders about generational differences in the internalization of that culture.
Sure. Yeah, no, absolutely.
I think that last comment fits with what I'm wondering about this culture of hero, the human as hero concept. And I wonder if you could say a little bit more about the attributes of that and whether speaking up or bringing up problems is within the list of attributes of a human as hero.
Well, let me actually be fair about those terms, because this human as hero, human as hazard, there's a fellow named James Reason, who is a cognitive psychologist and very well known in industry in general, from England, and those are actually terms that he uses quite a bit. And the reason why he's using those terms, and I think why I've been using them as I read his work, which is wonderful, is because we tend to have, there's a pendulum that tends to swing from the one direction to the other. All right? Now, historically, what we've done is that we in healthcare, we've always worked with the concept of human as hero, especially physicians. I mean, the expectation is when you're finished training, you come out, it's your individual excellence that is going to move you forward and ensure that nothing bad happens, and bad happens to your patients. And then it doesn't matter how bad the environment is, you will make sure that bad things don't happen to a patient. So this concept of individual excellence has been really key. Then with the the 1991 Harvard practice study, and that was followed by the Utah study, of errors in medicine, and that extrapolated to the 98,000 deaths. All of a sudden, human factors kind of arrived in healthcare, and we started saying, oh, well, wait a second. We're training everyone to to think of themselves as being infallible, but the fact of the matter is we're actually the hazard in the system, personally, the hazard in the system. And so the pendulum has now it swung quite a ways over. It's always the system that causes the error. It's not the individual. Well, and that's not accurate either. There's something in the middle. And what Jim was writing about in his most recent book, The Human Contribution, is this question of why is it that some places do extraordinarily well? Mayo does extraordinarily well. And I think a piece of it is because, and his contention is, this human is hazard. We know that. So we need to build systems around to protect those individuals from them, essentially from themselves and from the system. But if you want to see excellence, there's some kind of attribute in people that you have to draw on that makes them able to go that extra bit, that extra distance, that then generates the human as hero that allows you to be successful. What is it? I don't know. I see it here at Mayo. As I walk, I can see it. I can feel it. But why it's like that is an interesting question. I mean, it's a beautiful design, and you're all subject to its influences. Am I answering your question? Yeah.
Well, I just wondered about the speaking up. Is speaking up a part of being a humanist hero, or is that contradictory to be a humanist hero and speak up about problems?
Yeah, no, I don't think that's contradictory. That's a great question, all right? If you are knowledgeable enough, if the system is knowledgeable enough, I don't think the one has to adversely impact the other. Here's what I mean. Humanist hero, I want to put every ounce of myself into this work and to do it outstandingly well. All right, I really do. I'm going to be as vigilant as I'm capable of being. I will put in the extra hours and the extra effort, and I hope I'll be in the right place at the right time to help. I'm the hero. Now, I go and I get trained in human factors. I am fallible. I will err repeatedly and constantly. I need to know that. And I even know the kinds of errors that I'm going to make, and I know the ones that Steve's going to make because he and I are going to be working together. Well, now, the beauty is I can still be the hero, but I can get up and say I have a concern because I have enough understanding about human factors to know that I'd be an idiot not to mention the concern because we are innately fallible. So I don't think there has to be that they're mutually exclusive. I think if we train people effectively in human factors and then design systems for us to work in where we can speak up, where it's easy and so forth, that you can be a hero and still do it.
Thank you very much for a great talk. One practical question and one conceptual question. The practical question is, how in your moment do you empower and create that safe space so that the caregiver feels comfortable to raise the problem? And then conceptually, how do you do that in a virtual environment with virtual teams?
Yeah, well, big challenge. So, my compatriot who works with me, a guy named Mike Leonard, has a quote from a vascular surgeon named Whit Hollis, who I don't know, but he's out here in the Midwest, I understand. He was doing a big procedure, intravascular aortic stent. He had a whole lot of people who he's going to work with. And I've used that quote, I've used it clinically, and I'll tell you what it is because it's so simple. So, you come in, you're going to do the briefing. So, Steve, Joyce, James, we're going to be working together today. What are the practical details of the stuff we have to know, all right? Guys, you've heard me say this before. I'm going to say it again, all right? All we're going to do is get this right. If you see anything and if you see me do anything that doesn't make sense, speak up. It's 10 seconds. Now that's one example, all right? But it just gives you the sense. What's the likelihood that they'll speak up? I mean, the other thing is, hey, I'm fallible, you're fallible. If you see me doing something that you don't like, I want to know about it. It's admitting, human is hero, I am fallible. All right? And then that gives permission to folks to then speak up and do it. And I think now, virtually, I don't see any reason why, if I was sitting on a conference call, I wouldn't be able to say exactly the same thing. It's more difficult, but it's certainly doable. Yeah.
I noticed two things. One is you talk to your teammates by first name.
Always.
And the other was you seem to pick up on the catch them while they're doing something good before you catch them doing the errors.
Well, I mean, we can go into all the details here. So feedback about performance. The sense I have is in order for it to be successful in creating a learning environment, and actually, as it turns out, there's some provisional data to suggest that if you want to create an environment of psychological safety, it's actually more useful to be giving continuous feedback to people than it is to be telling them that it's okay to speak up. So what's good management? Well, good management is each day saying, here's how you did, here's what I'd suggest that you might do better. So if you do that, the likelihood is you're going to get people who are going to be more willing to speak up anyway. That means you have to define the unit, define the leaders, and have the leaders debrief at the end of the day to say, here's how things went. So yeah, so that's all wonderful points. Yeah. Good. Steve, thanks. Yeah.
We're out of time. Thank you so much for your efforts today and over the months with our culture survey. Have a good day.